We are live on YouTube and recording, ma'am. Ready to go, ma'am.
Shubha? Dr. Shubha, you are taking over?
Cindy will take over.
Yes. So, Dr. Tarani ma'am, she said she'll be joining soon, just in 2 minutes.
Cindy, you can start.
Okay. A very good afternoon to everyone here. Myself, Dr. Sini Venugopal. I invite you all on behalf of the CCC Wisdom Series team for our 24th episode of the CCC Wisdom Webinar Series. That is Confusion, Clarity, and Consensus in Infections in OB/GYN. And this is a very unique and a scientific program, and it has been very meticulously curated by our most dynamic Dr. Anju Soni ma'am, who needs no introduction, and who is currently the president of IMS. And today, our session, we have a panel discussion here, and that will be chickenpox in pregnancy guidelines of management. And for this a wonderful session, we have Dr. Ashish Mukhopadhyay sir as the moderator, and we have 6 wonderful experts as panelists. So I take this opportunity to welcome Dr. Anju Soni ma'am. She is the president IMS 2024 to 25 and also the governing council member of ICOG 23 to 25. And she has been the Secretary General of IMS, and also she has been the chairperson of the HIV and AIDS Committee of FOXI from 2020 to 23. And also she is member India CCM. She is the HOD of the OB/GYN department of the Sony Group of Hospitals at Jaipur. And her special areas of interest are high-risk pregnancy and critical care pregnancy. And she has been the recipient of numerous accolades and awards, and she's a very dynamic personality who has been very inspiring, and also she is the convener of this particular webinar series. So I welcome you, Anju Soni ma'am.
Thank you, dear. Thank you for your kind introduction. Today we have all these months we have been talking of infections in OBGYN, which is so important for all the practicing OBGYNs. And good afternoon, everyone. Chickenpox or varicella in pregnancy presents a unique set of challenges due to the potential complication for both mother as well as the fetus. And this panel discussion aims to explore the different scenarios that can arise when a pregnant woman contracts chickenpox, and the associated risks and the best practices for management are knowing the epidemiology and pathophysiology, the prevalence of chickenpox in pregnant women, how the varicella zoster affects the pregnant woman differently from general population, what are the mechanism of transmission from mother to the fetus, what are the maternal complications, the increased severity in the chickenpox in women, does it affect in a different manner, what are the potential complications such as pneumonia, hepatitis or encephalitis, and how do we manage the maternal chickenpox, including antiviral treatment and hospitalization criteria. Then next would be the fetal risk and complication, risk for the congenital varicella syndrome and its manifestations, time of infection during pregnancy and its impact on fetal outcome, the diagnostic approaches for detecting the fetal infections, the neonatal risk if the mother contracts due close to delivery, and what are the management treatment for neonatal varicella, the preventive measures including immunoglobulins, and what are the preventive strategies like vaccinating a woman during her childbearing age, screening and management of non-immune pregnant women, the post-exposure prophylaxis of the pregnant women who are exposed to chickenpox, and the case studies and scenarios. Real-life cases illustrating the complexities and varied presentations, discussions on decision-making processes and treatment plans, guidelines and best practices, review of current guidelines for management of chickenpox, recommendations from leading health organizations and experts, and also to increase the awareness and understanding of the risk and complications associated to provide healthcare professionals with practical knowledge, strategies, and discuss and develop senses on the best practices. We today have with us Dr. Ashish Mukhopadhyay, who doesn't require any introduction. He has been a avid teacher and a great orator. He will be moderating the infection along with the other people, other doctors from all over the India. We are going to have with us as experts Dr. Indra Papelio, Dr. Namrata Bharadwaj, Dr. Panchanand Das, Dr. Printa Ajay, Dr. Prasad, Dr. Sangeeta, Dr. Tharani, and Dr. Umrinitha. So I welcome all the experts, and I also would like to give the baton to Dr. Ashish to take over the further session.
Thank you, Anju. Thank you very much. And it's a warm greetings from Calcutta, the city of joy. It's lovely to see you along with your team organizing such wonderful webinars. And I was amazed to see the enthusiasm and your passion about infections in pregnancy. I really salute this because, you know, this is not a subject which we frequently discuss in medical fraternity, but it's extremely important to have the outlines that you have just mentioned. And I am extremely happy and honored, privileged to have such a wonderful galaxy of eminent specialists dealing with the subject. So, but thank you very much. Thank you, Anju. You have been doing this wonderful job. I have been observing you from a distance. I also observed you from a close corner when we were together in many occasions. So I think that I will put my respects and regards for all your passions and scientific outburst. So with that, I would like to welcome all the panelists that are presented over here. I think Dr. Indira Palo is there. Dr. Indira Palo.
Some faculties have not renamed them actually.
No, only one faculty hasn't remained. I think the rest three
of them.
Three of them, yes.
So if we would request every one of you to please click
rename yourself,
dots.
yes. That will
and rename yourself. That will be easier for everyone.
However, I can see Dr. Panchanand Das, my dear friend. Panchananda, welcome to the panel. And I heartily and cordially welcome you to the panel. I welcome Dr. Prasad Halkarnikar. Sir, you are from which part of
Kolhapur, Maharashtra.
Maharashtra, Sholapur, yes. Dr. Shubha Sethia is there. And Dr. Indira Palo, I cannot see. I know her very well. I just cannot see her. That's why I said.
Yeah, I think she has not joined, sir, because I just called her and she didn't pick up the call.
Yeah. I think she hasn't joined. I know her. The rest of the two faculties, please kindly rename yourself so that we can identify.
I'm trying to rename, but I probably cannot. I'm Dr. Namrata Bharadwaj, sir.
Madam, you go to the right-hand corner, upper part. You will see 3 dots there. You'll see
tried doing it, sir, but nahi aa raha usme.
Put a right click there.
Ranjit, can you rename Mr. Ranjit? Please rename Dr. Namrata.
Namrata, yes, Dr. Namrata. And
he's renamed it incorrectly. This is not Namrata Bharadwaj. I'm Namrata Bharadwaj.
Oh, I see. Yeah, there's a problem. Others doing for yourself. That's the problem.
Sorry, sir. I'm not able to do it. I was trying for a long time. Anju ma'am, namaste. Let me take this opportunity to greet you once again, ma'am. Thank you very much.
Nice meeting you, dear.
So I think that Anju is very much hard pressed for time, and it's very good quality that she maintains time always. It's a wonderful quality of life. So we will start the panel right now. In the meantime, please rename yourself, and let me see if I can share my screen here.
Dr. Indira Palu ma'am has also joined. I think she needs to rename herself probably.
Oh, that's very good. Welcome, Indira. Now, can you all see my slides?
Yes, it is busy. Sir, namaskar, sir.
Namaste, Indira ji. Namaste. I was looking for you.
So just go to full screen.
Yeah. This will be full screen only when I start playing. It is already full screen, madam.
No,
So
it
I'll
is
start
not.
playing.
It is not. Yes, now it is.
Yeah, yeah. Okay. So, Indira ji, namaste. Who else have joined recently? Or rest all have been introduced by Dr. Anju Soni. So, there is some echo there from some machine. Somebody is speaking from two machines. Kindly mute one of them. Okay. So the topic of discussion today is chickenpox in pregnancy. Now, this is one of the 8 viruses, 8 diseases which are caused in the human beings by the varicella group. So this is very important to know that we are dealing with something which actually is caused
You
by
need to, Ashish bhai, you need to go to slideshow mode.
Yeah, I'll go. Varicella zoster virus. This is one of the 8 viruses, and it's a double-stranded DNA virus. All of us know this. Now, when you have an infection even in the childhood, or if you have taken the vaccine, then 95% of adults will have serological positivity. That's a good sign. That means seroconversion is very good. Exposure is quite common in pregnancy. Chickenpox, all of you know, it's quite a commonplace occurrence, but the infection in pregnancy is quite rare. That is 3 in approximately 1,000. This is a UK data. In our country, we don't have much data, but usually approximately it is 1 to 2 per 1,000 pregnancies. Mode of transmission is by direct contact. It's the most contagious viral disease, and the respiratory transmission has also been reported. The incubation period is between 10 to 21 days, traditionally. Now, the problem is that in children, it is quite a mild disease, but in adults, it can lead to significant morbidity and mortality, particularly when in special conditions like immunocompromised patients or in pregnant women, they cause havoc. Also in pregnancy, we have another problem that the congenital affection may occur, leading to many congenital abnormalities. We discuss about them with devastating consequences. And all of us know that this virus causes 2 clinically distinct forms of the disease. One is the chickenpox, which we will discuss today, and another which we will not discuss today is the herpes zoster, skin rashes of the shingles. So I think that all of us actually are familiar with this infection. At the outset, I must talk about something about the vaccination, because this is one vaccine which is not included in the national immunization schedule or vaccine schedule. There is no vaccine schedule approved by government of India for chickenpox. We have to depend on the CDC recommendation. They recommend 2 doses of varicella vaccine for children, adolescents, and adults to protect against varicella. Children are routinely recommended to receive the first dose of vaccine between the age of 12 to 15 months, when they receive the mumps and measles vaccine and rubella vaccine. Along with that, they will take that, but of course, at 2 different sites. So MMR vaccine and varicella vaccines can be given once you are at 12 to 15 months of age group. And from that point onwards, the vaccine can be taken any time before 3 months of proposed pregnancy. So at least 1 month or more before pregnancy, you should take the vaccine maximum, because the vaccine is contraindicated during pregnancy. We'll come to that a bit later. And there are many vaccines which are available, which are approved by the government of India. They contain live attenuated virus derived from the Oka strain. The dose is 0.5 ml, which contains 1350 to 2000 units. The route is subcutaneous at the deltoid. Common forms that we use are Varivax or Varilix. 2 doses at 4 to 8 weeks interval. And as I said, MMR, if we are taking for the child, giving for the child, then give it in a different site, separate site. As I said, it's not recommended for pregnant women because it's a live vaccine. In general, we say this about all live attenuated vaccines during pregnancy. But as such, we can also say that till today, there has been no damage reported to the pregnant woman if inadvertently taken the vaccine. Therefore, we do not recommend termination of pregnancy in case of inadvertent vaccination during pregnancy. Now, this is the CDC recommendation about the vaccine versus the immunoglobulin. We'll come to a bit detailed discussion later on. Just a preface of that discussion here. As I said, from the live occur strain, we get the varicella vaccination. 2 doses, 4 to 8 weeks apart. The cost of the vaccine is about 1,500 rupees INR, and it is contraindicated in pregnancy. The rest of all information are all there. About immunoglobulin, we'll discuss a bit later. The dose is a bit complex, and the dose is multiple also. It is costly, 6,815 INR, but it is safe in pregnancy. There are some questions about the availability of the immunoglobulin in our country also. So with that, we invite our panelists into this case. We have 2 or 3 cases to discuss. And this one is a 35 years old, a bit elderly. She is 12 weeks pregnant and she's a primigravida. Accidentally, she went to a friend's house to inquire about her health as her friend was feeling under the weather. I mean, cough and cold. She stayed with her friend for around 20 to 25 minutes. The next morning, her friend called her up that she had got chickenpox lesions all over her body after she got the exposure. This lady consulted the internet straight away and read on the internet that has heard that chickenpox infection can harm her baby. And now she is worried and wants your consultation in this regard. So my dear panelists, come into play here now and tell me. I can't see the panelists, so I'm just minimizing my slides a bit. Let me see if I can see the panelists.
We are here, sir.
Okay. Dr. Indira, you start then.
Yes,
Dr.
sir.
Sangeeta.
Okay.
Yes, sir.
So now the question is, in this case, has she got enough exposure? Do you think that she has got enough
Yes.
exposure to contact?
Good evening, sir. Actually, your question is that it is significant exposure. Because significant exposure is when it is more than 15 minutes, then it is significant. And she has stayed with her for around 20 to 25 minutes. And when face to face, it is 5 minutes, again, it is significant exposure. So she comes under the category of significant exposure. That's why she is worried. And it is contagious from 1 to 2 days before the onset of the rash until crusting of the lesions. And if patient is non-immune and is exposed to the chickenpox, she should be managed as infectious if she has been given varicella zoster immunoglobulins. Then she is infectious for from 8 to 28 days. But if she has not been given immunoglobulins, then she is infected for approximately 3 weeks.
Okay. So she is not infective right now, you mean to say?
Yes, sir, she can be.
She can be. When does she become infective first?
When she comes in contact with her friends.
Okay. Now, we have to actually ask the patient and then take some good examination. When do the rashes appear? When do you expect the rashes in this moment?
Sir, incubation period is approximately 10 to 21 days.
Yeah.
So
Okay.
it can take
With
that
8 to
time
10
also.
days, she will get rash.
Okay. So now we have to ascertain the susceptibility of the patient, and as you said, that she will become infective very soon. So as Indira said, significant contact is more
Dr.
than
Sangeeta, sir.
15 minutes.
Dr. Sangeeta.
Oh, Dr. Sangeeta. Okay, okay.
Yes.
Actually, I can't see the panelists. That's why that's a problem.
Actually, sir, our video is on.
Yeah, video is on, no?
Yes, sir.
Why I can't see, I don't know. Anyhow, The slides are not moving also properly. Yes. So we need to ascertain the patient's susceptibility. How do you think that the patient is susceptible? On which grounds or what are the conditions in which you think that the patient is susceptible?
Sir, can I take this, sir?
Yeah, please.
Okay. So first thing we would like to find out is whether she's had a chickenpox infection anytime in her life earlier on.
Okay.
Number one. Number two, whether she's had a vaccination of chickenpox done at any point of time. The other thing is her ethnicity. Whether she, we don't know about this, but tropical climate patients generally tend to have low-grade infections and they are generally seropositive, these cases. Then, of course, you mentioned closeness and duration of contact. This we already know that she stayed with her friend for about 20-25 minutes. So this, and the very next day, the patient has, the friend has developed chickenpox rashes. She was at the peak of infectivity at that time when she had a contact with our patient. So these will point us towards the fact whether or not, and of course, whether our patient is, besides pregnancy, she has any other cause of being immunocompromised, whether she's on steroids or whether she's.
Yeah, I'll take your first question first. How do you ascertain that she has got chickenpox? At this stage, when she contacts you, because she's quite apprehensive, she hasn't developed the rashes yet. What are the symptoms that you expect at this stage?
Mild upper respiratory tract infection symptoms, sir, in the form of snivels and cold and maybe rashes will not appear so fast. Low-grade fever, sore throat. These are the things that she has.
That means non-specific symptoms, right? Which you can easily say that these are all cough and cold symptoms. Okay. But what special or what extra would you like to give her care in the form of? Any other panelist can opine?
Treatment of rash and the vesicles, which will appear within 1 to 2 days after her fever and common symptoms.
Mm-hmm. So now what will you advise her? Now that you have taken the history properly and you have not much of examination to be done, but you have taken the history that she has been exposed, or rather she has been in touch with the chickenpox patient, rash all over the body of her friend. That means chickenpox, you suspect chickenpox. What important advice that
we have to do her serological examination of varicella IgG to diagnose whether she is already infected with the disease or not. And accordingly, we have to plan her management.
Do you think that the IgG will be available so early, or it will take some time?
It will take some time.
It will take some time.
IgG. Hello, sir.
Yes.
This is Dr. Indira.
Yes, Indira.
Actually, there was a varicella zoster transmits with respiratory tract infection and also with fomites. She has been in contact with her for 15 to 20 minutes. But at this stage, we cannot ascertain or cannot confidently tell whether she will develop. Time only say we have to counsel her and we'll counsel her. If she develops any fever, malaise or anything, she has to report. And at present, in our clinical practice, we never do a IgG status. Actually, IgG status, if she had earlier infection, if she recalls that she had any infection prior to that, and we to know the immune status, if she cannot recall, then only the role of IgG is there. So now
I'll come back to you regarding the IgG testing when we should do it. But for the time being, I think our first job should be, number one, counsel her, as you rightly said, that see, there's a fair chance that you have contracted or you are going to contract chickenpox already. And the importance of chickenpox during pregnancy has to be highlighted to her. That is important. Second thing, you need to isolate that woman from the rest of the family members. I think it's too early to do that, but the family members also should be counseled that she is going to have chickenpox sooner or later. No question of testing, etc. But better be careful. And there are certain advice to be given or counseling to be done about the potential problems about the fetus also. So she can be contagious from 1 to 2 days before the onset of rash also. That's also important. So you need to caution her about this. Okay. And then comes the question of immunoglobulin, whether she has taken before or not, or vaccine she has taken or not. All these questions will come. We can always have those histories. And if she has taken a vaccine or has suffered from chickenpox in the childhood, probably she is protected from the severe outcome of the disease. Now, another part which we're not discussing today is the herpes zoster, the other manifestation, that is the shingles. Have you heard of any potential complication the
She
shingles
can have pneumonia. She can have hepatitis, encephalitis also. These
That is the
severe
complication
complications
of
can happen.
chickenpox also. So
Yeah.
any case herpes is there, body, these will have all the complications. We'll come to that later on. So we were talking about the susceptibility of the patient by history. There's a definite history of chickenpox, or she had received 2 doses of varicella vaccines. Then perhaps she is protected to the extent of 80 to 90%. That's very important. So these two histories are very, very important. But most of the times, the patients cannot remember. In the childhood chickenpox, most of the time they cannot remember. But once infected, that gives almost a lifelong immunity. Here comes the question of, I'll ask Indira. You were talking about IgG testing. When do you do the IgG testing? Do you really do it? Or you never?
No. In our clinical practice, we never do a IgG testing. But in a very person who is very much susceptible and she does not able to recall any history of previous infection, then to some cases we may advise, but routinely I have never done it. And it is also available or not, I don't know. So routinely we do not advise for the IgG testing. But if the patient is very precious pregnancy, the chances of baby fetal malformation is there and you want to confirm it, then you may go for a varicella IgG testing at that point only.
Okay, we have heard about some complications or other side effects following vaccination. Do you recommend IgG testing then? Any other panelist? Is it recommended?
No, sir.
In pregnancy, it is not recommended. We
No,
never
sir.
Not
give
pregnancy,
an
not pregnancy, not pregnancy.
Following a vaccine, we don't do an IgG.
Vaccination,
Don't do
yes.
it.
We are talking about vaccination now, not pregnancy.
Not after vaccination, it is not done. Not recommended.
So it is virtually never to be done. The IgG testing, it is useless expenditure. And not only that, it can misguide you also. Okay. So we don't recommend IgG testing. Okay. Now she was deemed to be significantly exposed. That's all right. She could not remember whether she suffered from chickenpox in her childhood. She was tested for IgG and found to not have immunity to chickenpox. That shouldn't have been done in the first place. What is your next plan of action now? So she is basically an unimmunized person who has been exposed to chickenpox. What will
So
you do?
she should be offered varicella zoster immunoglobulins as early as possible within 96 hours.
Okay. So visit IG you recommend. Okay. As you said, it should be as early as possible. Some people say within 72 hours. Some people say within 96 hours, but it must be given before the actual clinical picture is established. Once the clinical picture is established, there is no role of varicella immunoglobulin. So first of all, you select the patient who is non-immune, not immunized. Secondly, you give it as early as possible. And the dosage is 1 vial per 10 kg of the actual weight up to a maximum of 5 vials. So you need multiple vials injection. And in case where you take the immunoglobulin today and another exposure is reported after the cure of this condition, maybe, and 3 weeks after, 3 weeks have elapsed since the last dose, then you recommend another dose. So do you agree? All the panelists, do you agree? So immunoglobulin plays a significant role in the prevention of at least the severity of the disease.
Yes, sir.
Has anybody, our panelists, used this Visit IG? I have used it. Has anybody used this?
No, sir.
No, sir.
No, sir.
Okay. What is the most important
Sir,
problem?
is it available? Sir, is it available?
That's what I wanted to tell you. That my experience was that the patient hunted a lot and they didn't get, because it's quite scarcely available and it is quite expensive. So I think it's a challenge really to administer varicella zoster immunoglobulin. Look at this case. What happened? This immunoglobulin was offered to this lady. The risk of pain and erythema at the injection site and very uncommon risk of anaphylaxis, they were all explained to her. Obviously, you have to, whenever you give immunoglobulin, you have to do that, or even in vaccines also. Then she visited a couple of pharmacies and hunted for this immunoglobulin. Unfortunately, she could not procure it. This is a real life scenario. 2 weeks later, when she had almost forgotten about the incident, because वो नहीं मिला तो हम क्या करेंगे? I didn't get it, so she forgot all about it because the no symptoms also were not there. So little bit of no amount of push from within or in her family members to go for the extensive search for the immunoglobulin. So in the meantime, 2 weeks elapsed, and then suddenly on fine morning she noticed a rash and vesicular lesions on her body. Now she was terrified. All these days she were more or less okay, accepted the situation, and visited you again, second time, as she had read about congenital varicella syndrome on the internet. The first thing that you do whenever you have this rash, you consult the internet, Dr. Google. Now she has come back to you second time. How will you counsel her?
So first she needs to take into account the fact that she's 13 weeks or 12 weeks pregnant, and the risk of congenital varicella syndrome is very much there. So she needs to be counseled that she needs a proper follow-up of whether or not by ultrasounds, MRIs or whatever, so that the baby is secured. Number one. Number two, she should be started on antiviral therapy, because now the use of VZIGs are no longer relevant, and she requires treatment, full-blown treatment with antivirals.
Okay.
She should be first, sir. Both mother and baby should be treated first. She should be counseled that first we will consider whether you are developing any respiratory infection. So she should be counseled regarding antibiotic or any antiviral drugs. And for coming to the baby, we will counsel, because we cannot overnight, we cannot do a ultrasonogram, we cannot diagnose. It will take some time to diagnose. So we cannot, there is chances of having congenital infection to the baby is very rare. So we should not frighten them. We should have a positive counsel, and if anything such thing comes, then we will do a proper examination of the baby, and we will accordingly decide. We should not discuss all these complications to the patient. In the very first visit, the patient will get frightened.
We have to consult the patient regarding the fetal varicella syndrome, definitely, and congenital fetal infection also, but there is no chances of miscarriage. They should be explained to the patient. But fetal varicella syndrome should be explained and consult to the patient that this can happen, though there is rare chances, but it can happen.
Yeah, especially since she's already gone to Dr. Google and consulted herself. Now she knows exactly what all can happen. What Dr. Indra said was rightly said was, we should not frighten her, but we should make her aware. Yes, these things can happen, though they are not very, very common.
I think I'll just disagree.
0.5 to 1%, sir.
Indira, I'll just disagree with you, because if you don't tell her about this fetal varicella syndrome, she will be more terrified, because she will study the internet. आप recommend करो या ना करो, she will definitely go to Google and she will read all the complications, all the problems of fetal varicella syndrome, and she will get double this thing, terrified. So it is much better that a doctor should educate her about the fetal varicella syndrome. So can someone tell us about the fetal varicella syndrome? How much is the actual risk?
The actual risk is 0.5 to 2%.
Yeah. Okay.
It depends on the gestational age when she is getting infected. If it is less than 13 weeks, chances of congenital rubella syndrome is less than 0.5%. And if it is between 13 to 20, it is 1 to 2%. So according to the period of gestation, incidence varies.
Correct. So in the earlier half of pregnancy, first trimester, almost the risks are quite high, and the affection quotient is also quite high. If it is more than 28 weeks, practically no risk is there. So this suggests that there is some vertical transmission which is highest at the early half of the pregnancy. Early half of the pregnancy. And what are the problems that the baby may have in the fetus may have in the FVS?
Skin scarring, sir.
Skin
There is
scarring,
various
sir.
abnormalities. There is eye problems like cataract and microphthalmia, and chances of the neurological abnormalities like microcephaly, hydrocephalus, mental retardation, and bowel bladder sphincter dysfunction also, and skin scarring is there.
So all these awful things are going to happen in neurological complications. स्किन स्कारिंग तो चलो ठीक है, बाद में वो ठीक भी हो सकता है, लेकिन माइक्रोकेफली, कॉर्टिकल एट्रोफी and mental retardation, etc., these are almost irreversible conditions. Hypoplasia of the limbs is also, I think that these are quite potentially lethal consequences. So you need to explain these to them. But the chance, you must also explain to her that the chance is less, much less. And as the gestation advances, the chance becomes less. But this is not an indication for termination of pregnancy also, nor does it cause spontaneous abortion. So I think all these things should be explained properly in presence of her husband or some, accompaniment of her family. I think they should be explained these things. So as someone said that you need to go for acyclovir therapy. Now, can someone tell us the acyclovir dosage and duration of therapy, please?
I say 800 milligram.
800 milligram 5 times a day.
So I'm sure at this stage, nobody will recommend. At this stage, nobody will recommend Visitide. Hemoglobin को नहीं recommend. So the only thing
Sir,
is
there is
now.
echo in your voice.
Why should there be echo?
Someone's two systems are working. Please put one of them off.
Yeah, I am working from only one system.
So
I treat system as my wife, only one. Okay. So there is no role of immunoglobulin now. Once the chickenpox is developed, now that she has developed the symptoms of chickenpox. Yes, someone should tell us about the acyclovir. What?
800 milligrams 5 times a day to be started within 24 hours of onset of rash. And this has to be
for 7 days.
Okay.
This has to be continued for
It should be continued for 7 days, at least
7 days, yes. And any route of therapy, anybody can comment? Intravenous or
in mild cases, sir, oral will suffice. In case there are complications or very severe disease, we need IV cyclovir.
What are the complications that you are going?
Pneumonia.
Okay,
Pneumonia.
so the potentially devastating complication number one is pneumonia, which can give rise to respiratory distress and respiratory failure. There can be hepatic complications and encephalopathies also. So in case there is a respiratory problem along with these cases, which is the most common, we should switch to IV cyclovir and IV.
And also alteration in the sensorium.
Yeah.
When the patient cannot take and the question of absorption is limited. So I think those are the cases where the intravenous immunoglobulin, the acyclovir should be given, otherwise oral is sufficient. But the 5 times dosage in 7 days must be remembered properly. That's very, very important. And in cases of post-exposure prophylaxis, we'll recommend Visitide later on. Okay. Now that she is very much worried because she has heard about that fetal varicella syndrome, now she has conceived on fertility treatment, but also she agrees that, see, if it happens that that the fetus is affected, I don't want to continue this pregnancy. How much ever money I have spent on this pregnancy, it's an IVF pregnancy, costly pregnancy, but then I don't want to continue with this apprehension. I won't like to live with this kind of apprehension in my fetus. So how do you counsel this woman now?
She should undergo detailed ultrasound examination and then MRI, and amniocentesis can be offered but not routinely done because it has got a high negative predictive value but less positive predictive value.
Okay.
So I feel, as ma'am said, amniocentesis can be offered in case we get indications in the ultrasound and MRI of some potential congenital. That's what, no? Otherwise, not as a first time, as ma'am said.
But not routinely advised.
Not for the first, as first.
Ultrasonogram should be done after 2 to 4 weeks, so that we can help.
And serial ultrasonography to early detection of the defect.
After infertility is gone, after 2 weeks only we will do, and regularly, if there is nothing nothing abnormality detected, then we can repeat after another 2 weeks.
What do you see in ultrasound basically?
Limb deformity, microcephaly, hydrocephalus, IUGR, all can be seen in that ultrasound.
Okay, not in one go, but as you said, that it has to be serious. No, suppose you get one sign today, you see that there is some LRD, limb reduction defect, or then you see that some element of microcephaly. It's a serial diagnosis. It cannot be a one-point diagnosis.
One-time diagnosis.
Yeah. So ultrasound is very important and extremely useful for the diagnosis, and perhaps it is the most painstaking examination. Need to have a good sonologist will look at the baby from multiple angles, isn't it? Now coming to amniocentesis, as all of you have agreed that it has got a poor positive predictive value and very high negative predictive value. So if the normal finding is that it is very reassuring, but it may not find the actual thing that we are wanting. And also don't forget that amniocentesis has got an inherent risk of abortion as well. And if the baby is wanted later on by the couple, then you may regret that why did I go for this invasive test when it is not so useful. So I think ultrasound and rarely MRI, they are the useful investigations in such cases. So now we have started oral acyclovir. She was capable of swallowing tablets well, assimilating tablets well. Now we have started oral acyclovir. She's having that. She will continue to have that for 7 days. Ultrasound performed at 18 weeks of pregnancy that shows only microcalcifications of the liver, but no other finding. So the couple decided to continue, but in the meantime, doctor wanted to be doubly sure. So they had advised an MRI also. So fetal MRI is also performed, showing the same finding except microcalcification of the liver. Now, how much important this microcalcification of the liver is, and on the basis of which you can advise to continue or discontinue. Any panelists can opine? What does it suggest?
Microcalcification suggests there is some hepatocyte involvement. There are some damage has already occurred, but it is not significant. We can continue the pregnancy. There was some damage was there during the active phase of infection, probably, but it has been resolved, and now calcification has occurred. But probably there is no significant damage has occurred. When you can continue the pregnancy on this basis only, you cannot terminate or you cannot counsel how to terminate the pregnancy.
Yeah, thank you very much. I just add two things over here. That all said and done, chickenpox or varicella is a self-limiting disease. It's a viral disease. It's a self-limiting disease. Whosoever is the host, it will resolve automatically given time. Secondly, the fetal liver is one of the fastest growing organs in the body. It hasn't grown to its full extent in the intrauterine period. So when we deal with the newborn and the child is growing, soon you will find that these microcalcifications are all over. I mean, there is a possibility of resolution, 100%, if not 100%, 90% resolution of the liver once you give time. There are very occasional studies showing that these will lead to ultimately cirrhosis of liver and all those things, but they are very few and far between. So I think on the basis of the microcalcifications, none of us, the panelists, will go for the advice of termination of pregnancy. So she decided to continue the pregnancy and delivered a healthy baby at term. So the case conclusion is that the pregnancy was continued and she delivered a healthy child at term. So should we go to the next case, if you all permit?
Yes.
Okay. I don't know why these slides are not moving. I really don't understand. So I have to repeatedly shut this and reopen this. Okay, now come to the case 2. This time she is a 30-year-old pregnant woman who has skin lesions at 38 weeks of gestation, quite advanced pregnancy. And some general physician has diagnosed her as primary varicella zoster infection. Her clinical symptoms were high fever and generalized vesicles eruption. How will you manage her?
Sir, if her general condition is good, we can even manage her at home, number one. But she needs specific instructions. Isolation she requires proper hydration if she's able to take orally. Obviously, we will only send her home if she's able to take orally, otherwise we will not. We have to add an antibiotic because group-based streptococcal infections are very commonly associated with these vesicles. She has to be given soothing lotions because these eruptions, when they start crusting, they are very, very itchy and they are very, very troublesome to the patient. She needs to be taught about the danger signs that might develop and for which she might require hospitalization. She has to report to the hospital immediately. In case she develops cough or breathlessness or maybe altered sensorium, these are the indications then when we need to hospitalize.
Yeah, I think somebody talked about this pneumonia also in detail.
Yes, sir.
Yeah.
And I support the concept of the antibiotics in order to prevent secondary infection, but not the higher order antibiotics, but a broad spectrum antibiotic generally we recommend. Okay. And then if the patient develops some signs of incoming encephalitis or, cerebral hypoxia, I think those are the cases where you may offer her admission also. Pneumonia happens in around 5% of the cases. Encephalitis is further rare. But if the patient complains of frequent, dizziness of the head or fainting attack or something like that, then I think you can offer her admission as well. Now, whether if the patient is admitted, inpatient care, all of us know, you have already mentioned this. There are some more indications like neurological symptoms, as I just said, seizures, convulsions, or fainting attack, etc., or more than 100 lesions or a dense rash. These are the rough guidelines on the basis of which you can recommend admission and also for a closer follow-up. And there are some patient-specific risks also, like if the patient is immunosuppressed, she's receiving steroid for some time, last 4 weeks or something like that, then you got to go for the admission and isolation. And in the cases like this, when she develops neurological complication, that requires a multidisciplinary team. Okay. And what are the tests that you are going to advise on this patient? Suppose she's admitted in an HDU, high dependency unit. Then what are the tests that you are going to do on this patient?
Baseline investigations, definitely whether she is in HDU, CBC, LFT, and X-ray test is mandatory. And then we can go for, according to the condition of the patient, like electrolytes also, we can send on the patient.
X-ray test with an abdominal guard or the pelvic guard, isn't it?
Yes.
Okay.
And
Then
monitoring of the fetal well-being is definitely
how do you
mandatory.
do that? How do you do that?
We can go for the biophysical profile of the patient.
Mm-hmm. Do you go for CTG?
Yes, sir. We will go for
Yes, sir.
CTG.
Yes, sir.
Yes, sir.
So there are two weapons in our hand for assessing fetal well-being, and then ultrasonography, of course. But I think modified biophysical profile is very good, and sometimes CTG as well. The local treatment of the vesicles should be done promptly. And we have talked about antibiotics also. Now, there are some cases which I think our panelists have mentioned about the intravenous acyclovir, which can be given also in some cases. During delivery, what are the risks that she is going to face? Can you tell us?
So these are patients who are potentially at risk of hemorrhage, of encephalopathy, thrombocytopenias, and
Superadded infection of.
a lot of this is a time of pregnancy when we are not worried about the fetus so much as for the mother, because we've already established that the risk of congenital chickenpox is not so much at this age. But of course, the mother is going to is a big problem in this case, especially if she develops respiratory symptoms, because that is the time we would need to expedite delivery. And with all those potential risks of thrombocytopenia and hemorrhage and encephalopathies, it is a potential risk.
Correct. As we said earlier, we have discussed earlier that she runs a little risk of contracting this disease to her unborn child at this stage. But you're right. The patient may have some potentially lethal complications during labor and delivery, and therefore it's vitally important to stay away from delivery for some time. How long do you recommend?
7 days.
7 days.
Minimum 7 days. Yes, minimum 7 days. So you keep her admitted, don't discharge her, don't let her go home, but closely monitor her findings, and then you decide route of delivery. What route of delivery would you recommend?
when she is developing having varicella pneumonia and she needs assisted ventilation, then we have to deliver the patient. We have to terminate.
According to the
According to the
delivery should
obstetric
be conducted
indications,
as per the obstetric need.
obstetric indication. If she
As
requires,
per
of
the
course, she requires
obstetric
assisted
need.
delivery, then of course she needs.
Okay,
C-section.
suppose we decide
Otherwise,
for
normal
the
delivery.
suppose we decide for C-section, then what anesthesia would you recommend?
That is real.
Epidural anesthesia. Epidural is the safest.
Yes.
Sir,
With a
recently
long
we had a case of varicella zoster infection and she went into labor and actually her backside also infiltrated dense rashes were there. And the anesthesia preferred for general anesthesia. But the anesthesia discussing if there would not have any rash over the posterior aspect back of, then they could have preferred for the spinal anesthesia and or epidural. But thing is that as her back was also very much infiltrated with the lumbar region, they prefer for the spinal and general anesthesia. And the patient, her post-op was very uneventful, and she was discharged. Recently, only 1 month back, we had a case. Nothing has happened.
So the point is that we need to take a decision which will differ from patient to patient. But yes, epidural is perhaps the best. Unfortunately, do not get many trained epidural anesthetists these days. Everybody is preferring spinal anesthesia. So epidural anesthesia is very, very important. You tell your anesthetists that these are the risks that we are anticipating. Spinal anesthesia has got its risk, and general anesthesia also is maybe hazardous. So you have to leave it on him or her, but the antibiotic prophylaxis and all of the supportive measures must continue. And one good note of the oxygen carrying capacity of the tissues must be there. Okay, so timing and mode of delivery we have discussed. Elective delivery should normally be avoided for at least 7 days, as my panelists have said. However, delivery may be in women to facilitate assisted vaginal delivery. In cases of ventilation, as someone has also said, ventilation is the case where you cannot ventilate the bone.
Hello.
I think he had a problem with his bandwidth. That's why he got disconnected. So we have so many senior people. Dr. Das, we can continue the discussion on our own. Hello.
Hello.
Hello. Ji ma'am. Ji ma'am.
Am I audible to
Yes, ma'am, you are audible, ma'am. You are audible, ma'am.
Am I audible?
I think we can continue the discussion on our own.
Yes, ma'am.
Yes.
Ji ma'am.
So, what
Anju
are
ma'am, am I
the
audible?
prevention? Yes. You are audible, dear.
Okay.
Hello.
Hello. Hello. Hello, Anju ma'am.
Yes, yes,
Yes,
yes.
ma'am, you are audible.
I said, what are the
Madam, in between, sir has not joined. Madam, tell something about your CCC plan. What is the plan you are going to plan? In between, you can discuss with us, ma'am.
So basically, everybody talks of ultrasound, fetal medicine, and reproduction, and all those things. So we thought that this is a different thing, where infections.
So sorry, I lost the communication for a good period of time. I'm very sorry about this. Suddenly something happened.
It's part of
technology. Yes, a part of
Yes.
technology.
Yes.
So I think that we have covered most of the things. And is there anything else that we can discuss now? Let me open the file now once again.
Yeah.
Can you see now?
Yes, sir.
Yes.
Okay.
Yeah.
Sorry about this. Okay. So about that, elective delivery should be avoided for at least 7 days, more the merrier. And in the women who require assisted ventilation, you must, give it a priority and deliver first, because otherwise you cannot, resuscitate the woman. Anesthesia, we have discussed the theoretical risk of transmitting the viruses and all these things. The patient delivered a normal baby 4 days after she developed skin lesions. Now, the last part of the discussion is about the neonates. The neonatal implications are that once the fetus is escaped by an affection in the later half of the pregnancy, the neonate also may suffer. And there are many reasons for that. That is by direct contamination, direct contact with the mother's birth passage, or direct touch with the mother. So the first thing that you should advise the mother is, after delivery, my dear panelists, can you suggest what is the first advice you give to the mother after she has delivered the child with the chicken pox? I mean, the mother with the chicken pox.
In order to prevent neonatal varicella, we should isolate the baby from the mother till all the lesions have been cured or crusting has occurred. Secondly, as soon as possible, varicella zoster immunoglobulins should be administered to the baby.
Okay. Now, another advice I'd like to add from another panelist. Any other panelist?
There are two schools of thought, sir. One is there is definite that there is transplacental infection also occurs. So we think if there is already the baby has been infected and the baby might have gained some immunity. So if the infection, maternal infection is less severe, the baby we can keep the baby along with her. But if the infection is severe, mother is having severe pneumonia and other any encephalitis or very some life-threatening complication, the baby may be isolated. And also breastfeeding, you can squeeze the nipple breast and can retrieve the milk and you can feed the baby, and that is also will helpful to the baby to build up the immunity. So breastfeeding can be done. If the breast areola is not affected, then you can have with proper hygiene maintained, you can feed the baby. And also there should be counseling should be done. If the mother wants that she's educated, she wants no, I will not breastfeed the baby may be isolated. The baby from the beginning, the baby may be isolated. But the thing is, there is a danger of transplacental infection is also there, and also during vaginal delivery or during cesarean section, there might have some amount of contact is there.
Okay, so I think that the message is that either you isolate the baby from the mother, which is not very much supported these days by the neonatologists. They say, no, keep the baby shielded or guarded. Let the mother wear a mask and have some protective gowns, etc., so that the direct transmission is prevented. Yes, the concern is whether it is already transplacental passage is there or not. So that's the reason why we have two school of thoughts. But then about the breastfeeding, everybody is sure about this, that you should not stop breastfeeding, and while breastfeeding you should wear some protection. I mean the mask and other things. So that is about the unless the baby is severe fulminant neonatal infection, then of course you have to separate the neonate from the mother, and then the baby needs care, and we have discussed about the visit IGH also as well for the baby. So neonatal varicella can be prevented. The newborn should be isolated from the mother, and till the lesions have crusted and died, newborn should be dried. Newborn should be treated immediately with immunoglobulin, and as we have discussed already. Okay. So that's all. I think we'll have a lot of things to do, but there is no time now, and so we will skip all these discussions. And thank you very much, my dear panelists. You have done a wonderful job. And the third, this thing was about the breastfeeding, which we've already discussed, that we should not discontinue the breastfeeding for the child. Thank you very much for the participation in this.
Thank you, sir.
Thank you, sir.
Thank
you.
Thank you. And I once again thank Dr. Anju Soni for bringing up this topic and having some discussion on this topic, which is not very frequently discussed in scientific fora these days. Thank you very much, and hats off to Anju, and thank you very much all the dear panelists. Thank you so much.
Thank you, sir. Thank you.
Thank you, sir. Thank you, Anju ma'am.
Thank you, Anju ma'am.
Thank you, Anju madam.
Thank you, ma'am.
So,
you can
on
stop
behalf
sharing your
of
screen.
CCC webinar series, I thank Dr. Ashish Mukhopadhyay for such a wonderful moderation of the panel, because he made the panel interesting as well as very simple. The way you were speaking was excellent because it goes into our minds immediately. So, and a very good clinical approach to the patient, what we can encounter in our OPDs and how we are supposed to manage them. This was the best part of the whole thing. And I think the carry home messages were very clear, because VJED IG is not available. We have to rely on our clinical parameters, whether patient has been already infected or she has a history of vaccination. If we can get, it will be very useful. Otherwise, we must do a serial ultrasound of this patient to know, we must know, first of all, explain to the patient that there are very little chances of transmission of the infection, yet she has to be very vigilant about it. So serial ultrasound may be useful, and this will point only when there are abnormalities which are severe do we need to interfere. Otherwise, small abnormalities like as you said, calcification of the liver, we need not terrorize the patient. And then again, we have to be very careful when the baby is born, whether we need to give the immunoglobulins to the baby or not, and what are the consequences that can occur. And I think the panelists were all like, it appeared that we are just talking to each other, and we knew what is to be done. So I thank all the panelists, Dr. Indra Palo, Dr. Namrata, Dr. Panchanan Das, Dr. Pranita.
Shubha,
Yeah.
before you thank everybody, I would like to request everybody that I am going for the post of Vice President Foxy from West Zone. And I request each and every one of you to please vote and support for me.
Sure, ma'am. Sure, ma'am.
It's a soft request to each and everyone.
Sure, ma'am.
Sure. All the panelists have promised.
Thank you.
So the promise is not only from the panelists, but from all the people that they know. They must motivate everyone around them to vote for Dr. Anju Soni, because I think, sir, all of us have met her and we know how dynamic a personality she is. So she's going to definitely do good for the Foxy, and we need to have her in Foxy for her dynamism.
All the best, Anju. And all the panelists will get 100 votes for you. Each one of them.
Yes, sir. Yes, sir.
That is so kind.
Okay. So thank you very much. It has been a wonderful discussion. Thank you, everyone, for participating.
Thanks a lot, sir.
And I thank all of you who have taken out time from your busy practices and be here and given your insights in this such a crucial topic, because I know that all of us come across such cases. Even I have dealt with many cases in my practice.
Anju,
and I'm
ma'am,
sure
somebody has written, she's very beautiful, we will vote. Definitely, she's absolutely right.
So let us all come together and help all of our women in their difficult times. And in this series which we are conducting, we are talking of only infections in our day-to-day practice. And in coming webinars also, we have lots coming up. And I'm sure all of us with you who are there will enjoy each and every topic which our team have thought about, and we are going ahead with that. Thank you very much.
Thank you so much. So I'll take your leave because I have to attend another meeting now. Bye-bye and best of luck to Anju.
Thank you, sir. Thank you, Ashish sir.
Thank you so much. Bye-bye.
Thank you, madam. Thank you, madam.
Thank you, ma'am.
Thank you, ma'am.
Thank you, madam.
Thank you.